The Pelger anomaly refers to a genetic defect which results in characteristically bilobed or unilobed mature granulocyte nuclei. Dr. Carl Pelger, a Dutch hematologist, first described the morphologic features in 1928. Pediatrician G. J. Huët established the inherited nature of the abnormality in 1932 when he recognized it in a young girl along with several of the child's relatives. The general incidence of the Pelger anomaly varies from 0.1 to 0.01% but may be slightly higher in certain European populations. Neutrophils are most prominently affected and classically show a bilobed nucleus with the lobes separated by a delicate thin filament, so-called spectacle-like or pince-nez formation. The chromatin of affected cells is typically clumped and appears denser than that of normal granulocytes. This feature helps to differentiate Pelger cells from neutrophil bands which are commonly seen in a granulocytic left shift and have more open or lightly staining chromatin. Cytoplasmic granulation is usually normal. Other cell lineages, such as monocytes and lymphocytes, are unaffected. The morphologic phenotype is causally related to mutations in LBR, the gene that encodes the lamin B receptor. Lamin B receptor is a constituent of the neutrophil nuclear membrane and is required for normal morphologic development. The Pelger anomaly is inherited in an autosomal dominant fashion. In the heterozygous state, most of the neutrophils have bilobed nuclei. Individuals with homozygous Pelger-associated gene mutation are very rare and typically demonstrate unilobed nuclei in mature neutrophils. Heterozygous individuals with concurrent infection or systemic inflammation due to granulocytic left shift may mimic the homozygous state. Detection of dull bodies or toxic granulation provides clues to the presence of a left shift. Notably, individuals with Pelger anomaly do not appear to be at increased risk for infection, as their neutrophils retain normal functional capability. Neutrophils with identical nuclear features are occasionally observed as an acquired abnormality in association with various other clinical conditions, and in such settings they are referred to as pseudo-Pelger cells. These include myeloid malignancies such as myelodysplastic syndrome, acute myeloid leukemia, and chronic myelogenous leukemia. In addition, pseudo-Pelger cells may be detected in patients with infection and have been linked to HIV, influenza, and mycoplasma. Lastly, a variety of drugs including sulfonamides, colchicine, valproic acid, mycophenolate mofetil, and tacrolimus have been associated with pseudo-Pelger cells. The proportion of nuclei affected in these situations is variable, but normally segmented neutrophils are usually identifiable.